Welcome back to the deep dive. Today we're doing something a bit different. We're setting up a kind of war room. We have a very specific mission.
We do. Today is all for the MD Anesthesiology resident. And specifically for those of you gearing up for the Gujarat University exams, we know what that's like, we know the syllabus, and we definitely know there's one topic that can, well, it can make or break your viva.
Shock, sepsis, and MODS. They're pretty much the foundation of the specialty, isn't
Wow,
it?
it's the absolute bread and butter. If you can't manage shock, you can't be an anesthesiologist. It's really that simple.
And the examiners know that.
They do. They're not just testing what you've memorized. They're testing if you're safe. They need to know that you understand the physiology deeply enough to save a life when things go south.
Right. So I've got the books here. We're looking at Miller's, Marino's ICU book, Robbins for pathology, and of course, Guyton for the deep physiology. My job today is to be that sleep-deprived resident trying to connect all the dots.
And I'll be your senior faculty. My goal is simple. Cut through the noise. We're going to focus on exactly what you need to write for that big 20-mark question and, maybe more importantly, what to say and what not to say in that viva.
Okay, let's start right at the top then. The definition of shock. It sounds so simple, but I hear it's a classic trap.
It's the classic first-minute fail, honestly. If you walk into that exam and the examiner asks, "Doctor, define shock," and your first words are, "Shock is hypotension," you've basically failed the station right there.
Because you can be in shock and have a normal blood pressure.
Precisely. That compensated shock. Hypotension is just a sign, and often it's a late one. It is not the definition.
So what's the gold standard answer?
You need the definition from Marino or Robbins. You must say something like, shock is a state of acute circulatory failure.
Okay.
That's associated with inadequate cellular oxygen utilization.
Inadequate cellular oxygen utilization. That's the phrase.
That's the money phrase. It's a state of systemic tissue hypoperfusion. At its absolute core, shock is a supply-demand mismatch.
A mismatch between oxygen delivery, which is DO2, and oxygen consumption, VO2.
That's the one. You can have a pipe pressure of 12Z80, but if the cells at the end of the line aren't getting the oxygen, or they've been so damaged they can't even use it, that patient is in shock.
Right. What some people call cryptic shock.
Exactly. And if you miss that because you're just staring at the blood pressure on the monitor, your patient is going to die. That's why the definition matters so much to them.
Okay, that definitely sets the stage. Let's get into the pathophysiology then. You mentioned the supply-demand mismatch. What is actually happening inside the cell during this crisis?
Right. This is where you really score marks in your theory paper. You need to explain the cellular crisis. Guyton lays this out perfectly. Think of your cells as little engines, they run on oxygen, right, to power the Krebs cycle in the mitochondria and churn out ATP.
And ATP is the energy currency for everything.
It's the currency of life.
Yeah.
So when that oxygen supply gets cut off, the engine sputters. It has to switch to a backup generator.
Anaerobic metabolism.
Yes, glycolysis. But it's a terrible backup generator. It's incredibly inefficient. You get a tiny bit of ATP and you produce this toxic exhaust. Lactate, which is why it's our key biomarker for shock. But the real problem is when that tiny bit of ATP runs out completely.
The machinery just stops.
It does. And the most important machine is the sodium-potassium pump on the cell membrane. It's constantly working, using ATP to pump sodium out of the cell.
So when the pump fails, sodium rushes in.
It floods in. And what follows sodium?
Water.
Always. So the cell swells up with water. You get cellular edema. The mitochondria swell, the endoplasmic reticulum swells, and then the worst part, the lysosomes, which are basically little bags of digestive enzymes, they rupture.
The cell digests itself.
From the inside out. It's called autolysis. Once that cell membrane ruptures, that cell is gone, and it releases all that potassium, all those inflammatory mediators into the bloodstream, which then go on to damage its neighbors.
That is a terrifying cascade, a microscopic meltdown.
It is. And for the exam, you have to connect this cellular story to the DO2 versus VO2 relationship. You should be prepared to draw this graph. It's that important.
Okay, walk me through the graph.
All right, picture it. On the x-axis, you have oxygen delivery, DO2. On the y-axis, oxygen consumption, VO2.
Got it.
Now, normally, in a healthy person at rest, we deliver way more oxygen than the tissues actually need. The DO2 is about 1,000 mils per minute, but the VO2 is only around 250.
So there's a huge buffer, a big safety margin.
A massive one. This is the supply-independent part of the curve. The line on the graph is flat. If your delivery drops a little bit, say you get a bit anemic, your consumption stays perfectly stable, the tissues just work a little harder to pull out the oxygen they need.
So the oxygen extraction ratio goes up.
Exactly. But there's a breaking point. There's a sharp knee in the curve. We
Yeah.
call that the critical DO2. Once delivery falls below that critical point, the tissues can't extract anymore. They're at 100% extraction. And suddenly, for the first time, consumption becomes dependent on delivery. As delivery falls, consumption falls right along with it.
And that's the moment shock begins.
That is the definition of shock on a physiological graph. That's dysoxia. The cells are now officially starved of oxygen.
That's a really clear way to visualize it. So the body obviously doesn't just sit there and take this. What are the compensatory mechanisms?
Right, this is where you bring in your basic physiology. The first responders are the baroreceptors in your carotid sinus and aortic arch. They sense the drop in pressure or stretch.
And they fire signals to the brainstem.
Instantly. And the result is a massive sympathetic surge, a flood of norepinephrine and epinephrine.
So heart rate up, contractility up, and vasoconstriction.
Widespread vasoconstriction. The body makes a choice. It shunts blood away from the skin, the gut, the kidneys.
To save the brain and the heart.
To save the brain and the heart. Then you get the endocrine response, which is a bit slower. The kidneys sense low flow and kick off the renin-angiotensin-aldosterone system.
RAAS. So you get angiotensin II, a powerful vasoconstrictor.
And aldosterone to hold on to salt and water. At the same time, the pituitary gland releases ADH, or vasopressin, to tell the kidneys to conserve water. It's an all-out effort to increase volume and squeeze the pipes.
But sometimes it's not enough. Guyton talks about a vicious cycle.
Yes, and this is a key concept for understanding why shock can become irreversible. If those compensatory mechanisms fail, shock starts to breed more shock.
How does that work?
Low blood flow leads to tissue ischemia. The ischemic tissues, especially the gut and pancreas, start to release inflammatory toxins and something called myocardial depressant factor, MDF.
And that stuns the heart.
It does. So the heart, which is already working hard, now pumps even less effectively. Cardiac output falls further. That means even less blood flow, more ischemia, more MDF. It's a positive feedback loop of death.
Which is why you have to intervene early to break that cycle.
You have to, before it spirals out of control.
Okay, this is a perfect transition to the classification of shock. I know this is a standalone 20-mark question sometimes. How should we structure the answer?
The key is not to just make a list. Use a framework. The best one I've seen is Marino's hydraulic circuit analogy. Just think of the whole cardiovascular system as a simple circuit with three main parts.
Okay, what are they?
You've got the pump, which is the heart. You've got the fluid in the circuit, which is the blood volume. And you've got the pipes, which are the blood vessels.
Pump, fluid, pipes. Simple enough.
And you tie it to the fundamental equation of blood pressure. MAP equals cardiac output times systemic vascular resistance. MAP equals COX SVR. Every single type of shock is a failure in one part of that system.
All right, let's go through them. Number one, hypovolemic shock.
Okay, so in our circuit analogy, this is the tank is empty. The problem is the fluid.
So hemorrhage from trauma, severe dehydration, major burns.
Any cause of intravascular volume loss. So hemodynamically, what happens? Your preload, the amount of blood returning to the heart, is low. Your CVP will be low.
And if preload is low, then by Frank Starling's law, cardiac output will be low.
Right. And what does the body do to compensate and maintain that MAP? It has to crank up the SVR. You get intense vasoconstriction.
So the signature is low CVP, low CO, and high SVR.
That's it. And for the exam, you absolutely have to mention the ATLS classification of hemorrhage.
Right, the 4 classes.
Just briefly, class 1 is less than 15% blood loss, like a blood donation. You might not see any changes. Class 2 is 15 to 30%. That's where you start to see tachycardia.
Class 3 is 30 to 40%, and that's when hypotension usually kicks in.
Yes, and they'll be confused. And class 4 is more than 40%. That's pretty much pre-terminal. Just knowing those cutoffs shows the examiner you've done your reading.
Got it. Okay, next up, cardiogenic shock.
Right. So in our circuit, this is pump failure. The tank is full. In fact, it's usually overflowing. The pipes are trying to compensate, but the pump is broken.
The classic example being a massive heart attack, an MI.
A big MI, yes.
Yeah.
Or a severe arrhythmia, acute mitral regurgitation, something that cripples the heart's ability to contract.
So what do the hemodynamics look like here?
Well, because the pump can't move blood forward, it backs up. So your CVP and your pulmonary capillary wedge pressure will be high.
And because the pump is failing, cardiac output is.
Very low. And again, to compensate, the body clamps down hard, so your SVR is very high.
So high CVP, low CO, high SVR. How do you tell us apart from hypovolemic shock at the bedside? Those sound like they'd have cold, clammy skin.
They do. They're both cold shock. But the cardiogenic patient is wet. You'll hear crackles in their lungs from the pulmonary edema. You'll see raised, distended neck veins, a high JVP. The hypovolemic patient is dry, the neck veins are flat, and their lungs are clear.
Wet versus dry. That's a great clinical pro. Okay, number 3, obstructive shock.
This one is the pipes are blocked. It's a bit of a strange one. The pump is fine, the volume is fine, but there's a physical obstruction outside the heart that's preventing it from filling or emptying properly.
Give me some examples.
The big 3 are tension pneumothorax, cardiac tamponade, and a massive pulmonary embolism.
So hemodynamically, this looks a lot like cardiogenic shock, right? Blood can't get out, so it backs up.
It does. You'll see a low CO, a high SVR in response, and a high CVP. The key is the clinical context and specific signs.
Right. For a tension pneumo, you'll have a deviated trachea and no breath sounds on one side.
Correct. For tamponade, you're looking for Beck's triad. Hypotension, muffled heart sounds, and distended neck veins. An echo would show the heart being squeezed. It's a mechanical problem requiring a mechanical solution.
And finally, the really different one, distributive shock.
This is the tank is too big. Or, more accurately, the pipes are too leaky and dilated. The problem isn't the volume or the pump, it's a catastrophic loss of vascular tone.
Sepsis being the classic example.
Sepsis, anaphylaxis, and neurogenic shock. The vessels dilate so much that the normal blood volume is no longer enough to fill them. It's a state of relative hypovolemia.
And the hemodynamics here are the total opposite of the others.
Completely. This is the only major shock category where the primary problem is a profoundly low SVR. The vascular resistance has just collapsed.
And the heart tries to compensate for this drop in resistance.
It goes into overdrive. So initially, you often see a high cardiac output. This is the so-called hyperdynamic or warm shock phase.
Okay, and there's a huge VIVA trap with neurogenic shock, isn't there?
Yes, the heart rate trap. In almost every other form of shock, what does the heart rate do?
It goes up. Tachycardia is the classic sign.
Always. But in neurogenic shock, say from a high spinal cord injury, you've severed the sympathetic nerves that go to the heart. You've lost that fight or flight input.
So you get hypotension.
Plus bradycardia, a slow heart rate. If you're in a VIVA and you say a patient with a spinal injury is tachycardic, a good examiner will stop you right there and drill down on that. It's a classic mistake.
Hypotension plus bradycardia is neurogenic. Locked in. So this brings us to the overall clinical picture. You mentioned cold versus warm shock.
This is your first clue at the end of the bed before you even have any numbers. You just feel the patient's hands and feet.
So cold shock is for the low flow states.
Yes. Hypovolemic, cardiogenic, and obstructive. The body has initiated that massive sympathetic response, clamping down on all the peripheral blood vessels to shunt blood centrally. So the skin is cool, clammy, pale, and the peripheral pulses are weak and thready.
And warm shock.
That's what you see in early distributive shock, especially sepsis. The vessels are wide open from all the inflammatory mediators, so the skin is warm, it's flushed, and the pulses are strong and bounding, what we used to call a water hammer pulse.
Okay. And Robbins also talks about stages of shock. How should we use that?
It's a great way to structure your long answer. Think of it as a progression. Stage 1 is non-progressive or compensated.
This is where the sympathetic system and RA-ARS are working and the blood pressure is still normal.
Exactly. The body is managing. But then you move to stage 2, progressive or decompensated. This is where those mechanisms start to fail. Tissue hypoperfusion really begins.
So now you see hypotension, the patient gets confused, and metabolic acidosis starts to build up.
Right. And if it's not reversed, you enter stage 3, irreversible. At this point, the cellular and organ damage is so severe that even if you restore the blood pressure, the patient will not survive.
You know, we spend so much time looking at the monitor, but you always say to look at the window to the microcirculation. What do you mean by that?
I mean the skin. The monitor tells you about the big pipes, the macrocirculation. But shock is a disease of the small pipes, the microcirculation. And the skin is the only organ you can see.
So you're looking for modeling.
Yes. Look at the patient's knees.
Yeah.
That purple, lacy, web-like pattern, that's modeling, or levato reticularis. It means the microvessels are shutting down. And check the capillary refill time, the CRT.
Press on the fingernail in the sternum.
Press firmly for 5 seconds. If it takes more than about 3.5 seconds for the color to return, that's a very strong sign of peripheral hypoperfusion and correlates really well with high lactate levels.
Okay, so let's move into diagnosis and assessment. We're at the bedside. We've assessed for warm or cold shock. What are the key numbers we're looking for, beyond the basics?
2 things are more important than almost anything else. First, urine output.
The kidney is the canary in the coal mine.
It absolutely is. It gets a huge portion of the cardiac output, and it's very sensitive to drops in perfusion. If your patient's urine output is less than 0.5 mils per kilo per hour, they are in shock. I don't care what the blood pressure says.
And the second thing is lactate.
Lactate. We know why it's produced. A level over 2 is significant. But here's the next level thinking for your exam. Don't just look at a single number. You have to look at lactate clearance.
So, trending it over time.
Yes, you start resuscitation and you check another lactate in 2 to 4 hours. If it's coming down, that's a great sign. Your resuscitation is working. But if it stays high or is even rising, we call that lactate non-clearance. That's a very, very bad prognostic sign.
What about some of the more advanced monitoring, things like SCVO2 and the PCO2 gap?
Right. These are fantastic for showing a deeper understanding. SCVO2 is the central venous oxygen saturation. You measure it from a central line sitting in the superior vena cava.
And it tells you how much oxygen is left in the blood after the upper body has taken what it needs.
Exactly. It's a surrogate for the global balance between oxygen delivery and consumption. Normal is about 70%.
So if it's low, say 50%.
A low SCVO2 means the tissues are extracting a lot more oxygen than usual. The blood is moving slowly, and the starved tissues are desperately pulling every last molecule of oxygen out of it.
So that suggests a low flow state, like cardiogenic or hypovolemic shock.
Perfect. Now, what if it's high, say 85%?
That's counterintuitive. It means the tissues aren't using the oxygen.
Precisely. The blood is just rushing through the capillaries without offloading its oxygen. This can happen for 2 reasons. 1, there's massive shunting, which you see in sepsis. Or 2, the cells themselves are so poisoned they can't use oxygen even if it's delivered.
The cytopathic hypoxia we talked about.
Exactly. So a high SCVO2 in a sick patient is very worrying. And what about the PCO2 gap?
That's the difference between the PCO2 in venous blood and arterial blood.
Right. Normally it's less than 6 millimeters of mercury. Think about it. CO2 is produced in the tissues and needs blood flow to be washed out and carried to the lungs.
So if the blood flow is really slow and stagnant,
The CO2 will build up on the venous side, so a wide PCO2 gap greater than 6 is a very sensitive marker of a low flow state of inadequate cardiac output.
even if the blood pressure looks okay.
Even if the blood pressure is normal, it's a fantastic tool.
Okay, that makes sense. So we've diagnosed it. Let's talk management principles. We need a simple framework.
The best one is the VIP rule from Dr. Vincent. VIP.
VIP, what does that stand for?
V is for ventilation, I is for infusion, P is for pump.
Ventilation, infusion, pump. Let's break that down. Ventilation.
Oxygen, always. Put a mask on them.
Right.
But you need to have a very low threshold to intubate a patient in shock.
Why so early?
Because the work of breathing is metabolically expensive.
Yeah.
In a patient with septic shock, the respiratory muscles can consume up to 40% of the total oxygen delivery. By intubating, sedating, and paralyzing them, you eliminate that work. You take that oxygen and redirect it to the brain, the heart, and the gut.
That's a huge concept. You're resting the respiratory system to save the other organs.
Yeah.
Okay, acts as infusion, fluids.
Right. But the era of just blindly pouring in liters of saline is over. Fluids are drugs, and they have side effects: edema, acidosis, ARDS. The key question now is my patient fluid responsive?
How you check that?
The easiest way at the bedside is the passive leg raise, or PLR. You lay the patient flat, measure their cardiac output or a surrogate, and then raise their legs to 45 degrees.
Which gives them an auto bolus of their own blood from their legs.
About 300 mils worth. If their cardiac output or stroke volume increases by 10 to 15%, they are fluid responsive. They will benefit from more fluid.
And if it doesn't?
Then they're on the flat part of their Starling curve, and giving more fluid will only cause harm. It will just leak out into their lungs. You can use a quick lung ultrasound to look for B lines, which tell you the lungs are getting wet.
Stop the fluids and move on to P for pump.
Exactly.
Yeah.
This means vasoactive drugs. Vasopressors to squeeze the pipes and inotropes to improve the pump's contractility.
All right, this brings us to the elephant in the room. Sepsis and septic shock. The outline says this is an exam favorite.
It's guaranteed to be on your paper in some form. You have to know the sepsis 3 definitions inside and out. So first, what is sepsis?
It's life-threatening organ dysfunction caused by a dysregulated host response to infection.
The key word there is dysregulated. It's not the bacteria directly killing the patient. It is the body's own immune system going haywire in response to the bacteria.
So the pathophysiology is that cytokine storm.
It is. You have these pathogen-associated molecular patterns, PMPs, on the bacteria that trigger our toll-like receptors, and that unleashes this cascade of inflammatory mediators, TNF-alpha, interleukin-1, interleukin-6.
And this storm causes widespread endothelial activation.
Yes, and that leads to the three cardinal features of septic pathophysiology. Number 1.
Massive vasodilation from nitric oxide.
Good. Number 2.
Leaky capillaries. The endothelial junctions break apart and you get edema everywhere.
Yes, there's spacing of fluid. And number 3.
A procoagulant state. You start forming tiny little clots, microthrombi everywhere, which can lead to DIC.
Exactly. Vasodilation, capillary leak, and microvascular thrombosis. Plus, that mitochondrial dysfunction we mentioned earlier, that's sepsis in a nutshell.
So how do we define septic shock for the exam? It's a subset of sepsis, right?
It is. It's sepsis with circulatory, cellular, and metabolic abnormalities that are profound enough to substantially increase mortality. But for the exam, you need the specific clinical criteria.
Okay, what are they?
To call it septic shock, the patient needs to have sepsis. And despite adequate fluid resuscitation, they have two things. First, they need vasopressors to keep their MAP above 65.
Okay, so persistent hypotension requiring pressors.
And second, their serum lactate is greater than 2 millimoles per liter.
You need both, the pressors and the high lactate.
You need both. If you give a fluid bolus and the lactate normalizes, it's sepsis with hypertension, but it's not septic shock. It's the persistence of that high lactate despite fluid that really defines it.
That's a critical distinction. Okay, management, we've all heard of the Hour 1 bundle.
Yes, and you should be able to list its components from memory. It comes from the Surviving Sepsis campaign. Within the first hour of recognizing sepsis, you should do 5 things.
Let's hear them.
1. Measure a lactate level. 2. Obtain blood cultures. 3. Administer broad-spectrum antibiotics. 4. Begin a rapid fluid bolus of 30 mL per kilo if they are hypotensive or their lactate is above 4. And 5. Apply vasopressors if they are still hypotensive during or after the fluid bolus.
You stressed getting cultures before antibiotics. Why is that sequence so vital?
Because even a single dose of an effective antibiotic can sterilize the blood cultures, meaning they won't grow anything. If that happens, you may never know exactly what bug you're fighting or what it's sensitive to.
But there's a caveat, right?
Huge one. Do not delay antibiotics to get cultures. If you're struggling to get access or the patient is crashing, give the antibiotics. Every hour of delay in antibiotic administration increases mortality by about 8%.
It's a race against time.
It really is.
So when you reach for vasopressors, what's the first-line agent?
Norepinephrine. No question. It's a potent alpha-1 agonist, so it gives you great vasoconstriction to raise the SVR, but it also has some modest beta-1 activity, so it gives you a little bit of anotropy to support the heart.
What about dopamine? We used to use that a lot.
Dopamine has really fallen out of favor. Multiple studies have shown it's associated with a higher incidence of arrhythmias and potentially higher mortality compared to norepinephrine in septic shock. So, Norepi first. If that's not enough, you add vasopressin as your second-line agent.
And we can't forget the most important thing.
Source control.
Source control is source control.
You can pour in all the antibiotics and pressors you want, but if the patient has a ruptured appendix or an abscess, they will not get better until you surgically fix the source of the infection. You have to drain the pus.
Right. So if we fail to control all of this, the patient spirals into MODS, multiple organ dysfunction syndrome.
The final common pathway, the tragic endpoint. MODS is defined as altered organ function in an acutely ill patient, where homeostasis can't be maintained without medical intervention. It's the dominoes falling one by one.
Is there a typical sequence to the organ failure?
There often is. The lungs are usually the first to go. The pulmonary capillaries are incredibly sensitive to those circulating cytokines, so you get ARDS, acute respiratory distress syndrome.
After the lungs.
The kidneys are usually next. You get acute kidney injury, or AKI, from the combination of hypotension and inflammatory damage. Then the cardiovascular system itself starts to fail with what we call septic cardiomyopathy.
The heart gets stunned.
It gets stunned and boggy, then the liver fails, you get cholestasis and coagulopathy, the gut fails, leading to an ileus, the coagulation system completely breaks down into DIC, and the brain fails, which we call septic encephalopathy. It's a total system collapse.
For the exam, how do we tie all these concepts together in that integration section? Shock to sepsis to MODS.
You tell the story of the progression. You start with the initial insult. It could be trauma causing hypovolemic shock or an infection causing sepsis. You describe how this local problem becomes a systemic inflammatory fire.
And how that fire leads to circulatory failure, which is the shock state.
Yes. Then you describe the consequences of that circulatory failure at the cellular level, the dysoxia, the lactate, the mitochondrial death. And you explain that if the cellular injury is widespread and sustained, it manifests as organ dysfunction.
And the failure of 2 or more organs is MODS.
That's it. And a great way to conclude is to bring back Guyton's concept of the irreversible stage. You can explain that there is a point of no return, a point where even if you manage to fix the blood pressure, the underlying cellular machinery is so broken that recovery is impossible.
It really highlights the urgency of early and aggressive treatment. Okay, let's finish with some rapid-fire exam hacks. The common Viva traps.
Let's do it. Trap number 1. Define shock.
Don't say low blood pressure. Say inadequate tissue perfusion or inadequate cellular oxygen utilization.
Perfect. Trap 2. What's the best indicator that your resuscitation is working?
Don't say blood pressure. Say normalization of lactate or lactate clearance and a urine output of more than 0.5 mils per kilo per hour.
Excellent. Trap 3. Why is the skin warm in septic shock?
Because of peripheral vasodilation and a maldistribution of blood flow.
Good. Final trap. Does a normal blood pressure rule out shock?
No, because of compensated shock, where the body's reflexes are still maintaining the pressure despite underlying hypoperfusion.
You've got it.
And for writing the long answer, any tips for presentation?
Visual score marks. Always. First, practice drawing a simple flowchart of the classification of shock. Second, be able to draw and label that DO2 versus VO2 graph, making sure to point out the critical DO2.
And structure the answer clearly.
Yes. Use headings, definition, pathophysiology, classification, management, conclusion. And when you discuss the Hour 1 bundle, write it out as a clear, numbered, or bulleted list. It makes it easy for the examiner to read and give you marks.
That's incredibly helpful. Okay, can you give us the final elevator pitch, the 1-minute summary we can listen to on the way into the exam hall?
All right. Here it is. Shock is cellular dysoxia. It's a supply-demand mismatch of oxygen. There are 4 types: hypovolemic, cardiogenic, obstructive, and distributive. Sepsis is the body's dysregulated response to infection. Septic shock is sepsis that needs pressors and has a lactate over 2 despite fluids. Your initial management is the VIP rule: ventilation, infusion, pump. The ultimate goal is not just to fix the blood pressure, but to restore tissue perfusion and prevent the progression to MODS. And above all, treat the patient, not just the number on the monitor.
Fantastic. To everyone out there preparing for the exams, especially our listeners at Gujarat University, take a breath. You understand the physiology. Visualize the patient behind the question. Structure your answers. You can do this.
Absolutely. Best of luck. Go and ace it.
Catch you on the next deep dive.